Hi everyone, this is just going to be a quick little video addressing a point that I am really bothered by on the internet. Doctors aren't stupid, and studying medicine involves a lot of learning how to integrate a lot of information in your brain and get very nuanced answers. So this idea that if a trans person puts their preferred gender on a document, that somehow I'm not going to be able to figure it out what organs they have and then misdiagnose them with like a pregnancy or something is kind of ridiculous. We get really, really good at deductive reasoning in medicine. That's like most of the job. So I'm going to talk a little bit about what the medical thought process is like, because this is a crappy argument that doctors wouldn't be able to work through that kind of scenario and figure out what's going on. We can figure out a lot of stuff. There's a lot of times where you could just not tell us a whole lot of information and we could still figure out what's going on. We get really good at that. So here we go. We have a problem. This is from USMLE, or the UWorld's Step 2 CK test bank. So this is for the second round of boards, and I also use this for the shelf exam for internal medicine. And we have a lot of information here. These are like third order or fourth order questions. So the idea here is it gives you a lot of information, and it is your job to put all of it together and then work with that information to answer the question, but the answers are addressing a totally different part of the problem than what the question gives you. It's not like this A plus B equals C type questions. Like, we don't follow this algorithm and just get to an answer by like pattern recognition. That's not how medicine works. That's not how good clinicians work. You need to get really, really good at working with information, actually confirming if information gives you an answer or not. So we have this 68-year-old man coming to the emergency department with a 3-week history of progressive dyspnea, orthopnea, lower extremity edema. So you have to know what all of these mean. You have to know this age group. And then you give a past medical history of hypertension, type 2 diabetes, myocardial infarction 8 years ago, and congestive heart failure. So you have to understand all of these medical conditions. You have to understand the significance of having an MI 8 years ago as opposed to last week. You're given a list of 6 medications. You got to know all these medications, what they do for this person, kind of what side effects they might have. What are you thinking? Is there anything standing out to you about this medication list? You get a set of vitals. You get a physical exam. So you got to know what this means. You got to know how these vitals reflect that. You have to know these lab values. You have to know some calculations with these lab values. I have to calculate I can calculate anion gap from, well, I can't really because I don't have a bicarb. But you can calculate some stuff from these labs. We're given an EKG, and you got to understand what that means. And then here we have our answer choices. So you read through this case, and you get a pretty good idea of what issue is going on here. But it's not asking you for a straight-up diagnosis. It is asking you for some pathophysiology in some of these. It's asking you for pharmacology in some of these, like side effects of pharmacology. It's asking you for prognostic indicators. The answer here, hyponatremia, is a prognostic indicator. So you got to know that. You got to know digoxin. You have to know the effects of norepinephrine on this patient. So you have to know a lot of things to be able to answer this question correctly. And it's a lot of integration in your brain to get this correct answer. So we can go through questions like this all of the time, and keep in mind, we have tests that are 8 hours of these types of questions, and yet somehow people seem to think that we can't handle questions like this. So we have somebody whose name is Rosie Smith. She is a female. Her chief complaint is abdominal pain, and her past surgical history. She had a penile inversion vaginoplasty and a labiaplasty, and her medications include an estradiol transdermal patch. Whoa, maybe I shouldn't assume this person is pregnant. I don't think I could even make that assumption because, look, I understand. I understand that this is a trans woman, or at least someone who's trans femme. You have someone who's female, who had a penile inversion vaginoplasty and is taking estradiol. Whoa, this isn't a lot for me to even deduce here. Like, this isn't a complex scenario. So it's kind of funny that y'all think we're stupid and that we can't solve a question like this. People citing malpractice cases and talking about how, oh, well, if the doctor knew that this person was trans, there wouldn't have been malpractice. We can handle this information. We can handle this little bit of information and stop using that argument that we don't know what we're talking about to justify transphobia. I'll see you all in the next one.